سيدنا وحبيبنا ونبينا محمد وعلى آله وصحبه أجمعين. We are going to continue standardized mammographic reporting based on SR lexicon. As you know, the American College of Radiology developed reporting system since 1992 for mammography, and 2003 include the breast MRI and ultrasound, and updated at 2013, the latest 5th edition. And the ACR by RAD provide the framework for reporting, lesion assessment, imaging, pathologic correlation, and quality improvement. And it's recommended to use it. Okay, so report should be concise and organized, and based on the lexicons, the structure format for the reporting, including description for indications of the study, and then press composition, and to describe clearly the important findings as described in the lexicons, including the mass, asymmetry, classification, distortion, and associated findings, and if relevant, compare it with the previous, if available, and then to conclude into a final assessment category. Accordingly, give management recommendation, and for unsuspected finding, you have to communicate with the referring clinician or the referring physicians. And already we have talked about the various items. See, we said we have to describe the indications, if it is screening or diagnostic, and if it is diagnostic for the following screening, or there is clinical abnormality or follow-up of probably benign lesion, and if there is clinical history, you have to briefly put it in the report first. And before you evaluate your image, you have to evaluate it or to assess it for the quality, and to make sure the image having technical adequacy. Then you have to assess the press composition, and this will reflect the accuracy of mammography, and the clinician will understand how this mammogram is sensitive. And as we said, we have 4 types, and usually it's visually estimated by the radiologist, but currently there is automated approach. And we said the high density, you see, the least sensitive mammogram that preclude the visualization of a cancer, underlying cancer. Then we shift and we revise the mammographic abnormalities, you see, and we mentioned that the standard report, after describable indications and composition, then you have to describe any significant findings in the mammogram. And we went through these and we revise it all, the masses, asymmetry, calcifications, associated features, all these significant findings, it should be described according to standardized terminology available in these ACR lexicons in terms of potential for malignancy. And we said we have to have approach to evaluate the mammography, and preferable to use the mask technique. Put first back-to-back CCs, again is the CC, and MLO again is the MLO for 2 breasts back-to-back to make a mirror image, and then use the mask visualizing the same area in 2 breasts like this, and you can use it in the perpendicular direction also. So it will be easy to pick any abnormality and use the mirror image. It's also helpful to visualize what is going on. And we said we have to review the forbidden area and to be aware about any asymmetry in the bar zone, not to be missed. And also we have to just to remind you about the ARC technique and these techniques that can help you, you see, to visualize or a focal asymmetry or an asymmetry seen in one mammogram. You see, when a standard view could not be visualized in the other view, just use the technique searching for comparable size, comparable density of these asymmetry in the perpendicular view. And we talked already about the importance of comparison to the previous, and the report should include, or there should be a notation about a comparison with previous study by dates. And if there is no available previous, it's preferable to mention there is no comparison was made or no available previous to compare with or whatever. And you know that the importance, if there are multiple prior studies, to compare with all of these is crucial, as you have seen in many examples, how it can help sometimes in between. Maybe the lesion previously was available but missed due to any technical issue in the following mammogram. Or sometimes the difference in size of a lesion cannot be appreciable since the last year. But when you compare it with the previous many years back, you might notice the difference. Okay, then today we are going to shift for the assessment categories. After you describe all of these we have mentioned above, then after you find your abnormality, describe it precisely, you see, using the standard terminology in the lexicons, compare it with the previous, you have to assess it, to code it into a certain mammographic category according to the BIRAD lexicons, which include from 0 to 6 and associated, the phrase associated with them. 0, BIRAD 0, and what does it mean? BIRAD 6, what does it mean? If mammography and ultrasound are performed, overall assessment should be based on the most abnormal of the two and based on the highest likelihood of malignancy, the most suspicious findings. And we should not forget to correlate these findings with the clinical informations and integrate mammography and ultrasound findings in a single report. Then we have to give management recommendations according to the BIRAD category we conclude to. For the management for future action where appropriate. Okay, and we describe already, we have 7 categories from 0 to 6 linked to 4 possible outcome management, because some of which sharing the same outcome. And here you can see these categories from 0 to 6 and the managemental likelihood of cancers. 0, it means that more information is needed, the study is not complete, recall for additional imaging and wait for prior examinations. And BIRAD 1 is negative, normal mammogram, just the patient for routine screening, essentially 0, the likelihood of cancer. same as for BIRAT 2, same management and risk of cancer, which represent the benign findings. BIRAT 3 is probably benign findings, you see, for short-term follow-up, and the likelihood of cancer above 0, but less than 2%, equal or less than 2%. While BIRAT 4 are suspicious findings, it needs tissue diagnosis and divided into three categories. And BIRAT 5 is highly suggestive of malignancy, also same management as BIRAT 4, which is tissue diagnosis, with the risk of cancer for BIRAT 5 is more equal to 95% or more, and BIRAT 4 is between 3 and 5. And category 6 is non-pathologically diagnosed breast cancer and management surgical excision when clinical appropriate. Here, this is more detail, you can read it. Okay, this is a screening mammogram. What is the BIRAT category for this?
Zero.
You want to go quickly?
Zero.
Zero. Excellent. Zero. Why it is 0?
Because in screening we have either 0, 1, or 2. 1 is normal, and 2 is benign lesion. Since this is not, then it will be 0. It needs additional imaging, like more views with ultrasound.
Excellent. Excellent. We said the new recommendations is either for screening is either positive or negative. Take more action, positive, take more actions, or negative, continue screening. You see, positive, whatever it is BIRAT 0, 3, 4, 5, they consider it positive. Then all of these reported as BIRAT 0 that need further actions, further workup, and or just BIRAT 1 or BIRAT 2 considered to be negative. So this is before reported as probably benign, but now in screening mammography it's being reported as BIRAT 0, and then ultrasound performed and revealed
Intramammary lymph node.
So it will be BIRAT
2.
See, then it will be BIRAT 2. Okay. So then later we are going to discuss how to make sure that we are dealing with the same lesion in the 2 different modalities, which is essential. Okay, what about this case? Palpable abnormality. So we are dealing with which type of mammography?
Diagnostic.
Diagnostic. Huh? What's the abnormality? What is the BIRAT, I mean? BIRAT category?
4.
Why it is 4?
Sorry, just let me go step by step. There is an asymmetry involving the global asymmetry involving the left breast.
Okay.
You have a sorry.
Or mass.
You have to ensure the quality of the image. If it is
excellent, 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 excellent. The image quality is not inadequate. So this we cannot comment on. Just we will report it as
0.
Zero.
This it will be 0. Or if the patient in the department, you ask the technologist before you give the report, you ask the technologist, go and repeat it. But this, my patient, she refused to repeat the mammography. She was not cooperative since the beginning. That is why it was like this. So next step, it will be
Ultrasound.
ultrasound. Okay. Then after ultrasound, it is
yes.
Viral
4C or 5. It's okay. So we said category 0 assessment is incomplete. Why? That means possible abnormality may not be clearly seen, or there are findings need additional imaging evaluation as a spot compression, magnification views, special mammography views, or ultrasound, or a comparison to prior mammogram is needed. This to see if there have been changes in the area over time. See, when additional imaging studies are completed, then we have to give a final assessment from 1 to 5. This almost always used in screening situation. Sorry, it should rarely be used after diagnostic workup or in diagnostic mammography. Why? Try always in diagnostic mammography to prepare the prior studies before starting your new mammography. See, so it will help you. But there are certain situations we'll talk about in which we can use BARAT 0 in diagnostic setting. So the management recommendation is, since we are using in screening, it will be recall for additional imaging or comparison with prior. And it should be specified. We should not say just recall or just BARAT 0. You see, incomplete study. We have to describe why it is BARAT 0. What is next step supposed to be? Is it for comparison to prior? Is it for further or additional images, mammographic images, or ultrasound, or all of these? So the terminology used, it can be incomplete, need additional imaging evaluation and or comparison with prior studies. Incomplete, comparison with prior study is required. Need additional imaging evaluation to complete the assessment. Any terminology, you can use it from this. Okay, when we have to do BARAT 0, if a mammogram examination is not assessed as negative or benign, the current examination should be compared with prior examination. It's also used to indicate the recommendation for additional imaging evaluation, as we said, and this like use of spot compression with or without magnification or other special mammographic views or ultrasound, and also to be used for technical repeat examinations. Category 0 should be used only when such comparison for additional imaging are required to make the final assessment. Okay, like if there is a focal asymmetry, so can be dismissed either a normal variant or benign finding by demonstration of stability or so, for example. Okay, under certain circumstances, we said we can use it in diagnostic setting, like if the equipment or the personnel are not available at the time of doing the study or performing the study, so or that the technologist is not available to do additional mammographic views or to do an ultrasound, or the patient herself unable or unwilling to wait for completions of her full diagnostic examination, then we allow to use the BIRAD 0 in diagnostic report. What?
ايوه ان شاء الله يعني اصيب.
الو
زوجته ايوه بس اصابات خفيفه يعني من الاصابات اللي يعني الحمد لله انه خفيفه.
ايوه
اوكي.
ايوه بسيطه.
وين
يعني انت ما
كاتيجوري؟
أصبت اثناء الشغل.
الحمد لله
وين
لا لا يا زلمه
الصحة كلنا والله احنا
Excuse
القسم
me.
عندنا كله اصيب.
لو سمحت
حتى انت
excuse me
لا السلامه.
والله.
could you
لا يا زلمه
mute
والله
your phone
في
please?
دكتوره معرفه الله محمد توفيق.
Okay. When category 0 is used in the next of awaiting prior examination for comparison, it should be in place a tracking system granting with 100% reliability that the final assessment will be made within 30 days, preferably sooner. If even if examination do not become available. After comparison, make a final assessment and issue addendum including revised assessment. Comparison will affect the final assessment. What does it mean? If you put one assessment, you see final assessment, you put category 0. After you revise with the previous and you find that the assessment, it will be 1, 2, 3, then the final assessment, it will not be 0. You see, the final assessment, it will be the new assessment you added as an addendum. And you should contact or communicate with the referring physicians to inform him or to provide him and acknowledge him by this new assessment. When we should not use BIRAD 0. Some breast imaging practitioners may reasonably choose never to use category 0 if they are not sure, okay, the prior images will be available within these 30 days. They have no guarantee that the prior images they can achieve it. Don't use prior mammography or ultrasound. Don't use category 0. I mean, if the previous imaging are not available and not required to make the final assessment. You can judge and give the final assessment before you find the previous one. So no need to use BIRAD 0. And also don't use BIRAD 0 if the final assessment or if the findings are irrelevant, like inherently suspicious findings. So it's not going to be affected by the previous images. No need to wait and to put BIRAD 0. Also, don't use BIRAD 0 for if mammography performed concurrently with ultrasound. So no need. We have to judge after ultrasound. We have to judge and to give a final assessment categories. We should not put or use category 0. Don't use category 0 for finding that warrant further evaluation with MRI. You have to put a final assessment, okay, complete assessment before recommending breast MRI. Okay, what about this? Hello? Hello?
Yes. Too. So.
Did you hear me?
Yes.
Okay. You are following?
Yes,
thought,
yes,
I thought,
yes.
thought
So
that-
this is 0. Yes.
why it is 0?
This is screening mammogram, yes?
What?
It is a screening mammogram, yes?
No, not screening. Yes, it is a screening mammogram. Yeah, it is a screening mammogram, but it is it positive or negative?
It is positive in the right
Why?
breast. The right breast, there is
Slightly more the parenchyma in the right breast more than the left breast, but the CC view doesn't show any more findings.
oh, okay.
So
So it
No.
will be it will be 1.
well,
If the CC is normal,
yes,
where is the C? It's not there. Mhm.
it's not available. Yeah. Okay.
Mm,
So this is by RAD1.
yes. Okay.
So by RAD1 assessment is complete. Is negative mammogram. Nothing to comment on. There is no asymmetry. There is no masses. There is no calcification. There is no architectural distortion. No skin thickening. No nipple retraction. No trabecular thickening. No adenopathy. No any abnormality to comment on. So the likelihood of cancer is essentially 0. And the management just continue routine annual screening. Okay. This is a normal mammogram, but the patient is diagnostic mammography and the patient having a palpable abnormality.
So it will be 1, but she has to correlate it clinically, and you have to write that she should correlate it
Yes.
clinically,
Yes.
or
Yes, you are right. Yeah, so we have to do by RAD1. Yes, by RAD1, but since the patient having palpable abnormality, we should add a sentence, recommend surgical consultation or tissue diagnosis if clinically indicated. Based on clinical, they have to take a biopsy. And some recommendation that they said it's important to add a disclaimer, you see, at the end of the report that can protect the radiologist, like not all breast abnormalities show up on mammography. The management of palpable abnormality must be based on clinical ground. And if you detect for the patient, if you detect a lump or any other change in your breast before your next screening mammogram, consult your doctor immediately. Okay. What is the BIRAT?
BIRAT 2.
Excellent. Yeah. And what is this? What is the BIRAT?
BIRAT 2 also.
BIRAT 2. Yes. Okay, so BIRAT 2 is like BIRAT 1, is complete and consistent with benign findings, benign abnormality, benign abnormalities, benign mammogram. Whenever you want, whatever you want to select to use from this terminology, you can use it. And it is like BIRAT 1 is normal assessment, but the interpreter chooses to describe benign findings in the report. What are these benign findings like?
Fat containing lesions.
Fat containing lesions,
Benign calcification.
Benign calcifications like?
Like skin
Commonest.
vascular
Yes.
calcification.
Yes, yes, secretory
mastitis,
popcorn,
hyperoadenoma,
diluting
hyperoadenoma, and
okay.
Less dense mass on mammogram. Dense mammogram, but become less dense on spot magnification view or spot compression zero.
You start to confuse. You start to get confused. Huh? What are benign
foreign body.
findings? Benign
Implants.
findings. Huh?
Breast implants or any foreign.
Breast implants, okay. Huh? What else?
Intramammary lymph nodes.
Intramammary lymph node, yes. Huh?
Single dilated duct.
No. We did not say single dilated ducts.
Fibroadenoma that are not changed at least 2 years follow-up.
Excellent. Fibroadenoma, stable, presumed mammographic fibroadenoma. You have probably benign lesions, presumed to be fibroadenoma, stable for at least 2 or 3 years. Okay, excellent. It will be BIRAT 2. What else? Huh? We have a lot of cases. You want to go quickly.
Follow-up of breast after breast conservative surgery.
Excellent.
But you have to ensure it is due to this intervention or this conservative
interventional changes. Excellent.
Yes.
Excellent. Well done. Yes, benign calcifications, calcified fibroadenoma, probably fibroadenoma that unchanged for at least 2 or 3 years, fat-containing lesions like lipoma, oil cyst, galactosile, mixed density like hamartoma, intramammary lymph node. The implants, and also we said include follow-up after conservative surgery, a distortion clearly related to prior surgery, while still concluding to protect yourself, concluding that there is no mammographic evidence of malignancy. So they might proceed if they have clinical suspicion, they might proceed further. See, if the breast is dense or like that, and they have any clinical suspicion, they might proceed for MRI or for biopsy or whatever, and they might find residual disease or like this. So, but based on mammography, since we could see only distortion of post-operative, we have to say BIRAT 2, but we add this sentence. Okay, but all of these changes have to have a characteristic benign appearance that should be labeled with confidence. Category 2, considered to be negative, both on diagnostic and on screening setting or in screening setting. It is a negative study. No cancer is there, no follow-up, nothing before the next screening mammography. And we said the likelihood is for malignancy is essentially 0, and the changes mentioned in the report to ensure that others who look at mammogram will not interpret the benign finding as suspicious, and these recorded findings in the report will help when comparing to future mammograms. So the management, it will be like BIRAT 1, just routine screening mammography. Okay. What is your comment about this BIRAT, this image? Part of mammographic image, demonstrate.
Diffuse calcification. Represent this diffuse.
Diffuse is scattered.
Amorphous.
But the morphology, amorphous, excellent. Amorphous, diffuse scattered calcification. So it will be BIRAT?
BIRAT 2.
BIRAT 2, excellent. Usually seen with adenosis. Diffuse amorphous calcification. Okay, so this is opacity seen on mammography, but on ultrasound represent a simple cyst. So the BI-RAD, it will be 2 based on this downgrading ultrasound. So when we have to do BI-RAD 2, use it in screening or in diagnostic imaging when benign findings are present. Use in the presence of bilateral adenopathy, probably reactive or infectious in origin. We are sure that these are reactive or infectious. Then we can report it as BI-RAD 2. Use in diagnostic imaging, okay, and recommend management if appropriate in a case of abscess or hematoma or in case of implant rupture. But don't use it when a benign finding present and the interpreter may choose not to describe such findings in the report. In this case, should not report it as or code it as BI-RAD. It has to be coded as BI-RAD when. Because it is not described, since are not described in the report, no need to put, or is better not to categorize as or code it as BI-RAD 2. Don't recommend BI-RAD 2 lesions MRI to further evaluate a benign findings or BI-RAD 2 lesions. Okay, what about this? This is a lady, you see, 64-year-old female, diabetic hypertensive, chronic heart failure, chronic renal failure on hemodialysis. This is her mammography. On admission, they had done for her a mammogram. Because she's sick, the imaging is not a mirror image, not a perfect mammography. No one would like to comment on?
السلام عليكم.
عليكم السلام.
مساء الخير دكتورة.
وعليكم السلام. عبير ولا منو؟
أيوة يا دكتورة. It's
اتفضلي.
BI-RAD 2. It shows tram-like vascular calcification. And it showed breast edema. And as you mentioned in her history, she suffered from heart failure and renal failure, so fluid overload. So all these findings are benign findings.
Okay. Excellent. Well done. Anyone he has other opinion?
Yes, there is a calcification, which is suspicious calcification at the right breast, representing polymorphic calcification.
Where is that calcification?
At the middle, retroalular, at the right breast.
Okay. This is not rod-like calcification.
Not like rod calcification, because rod calcification go to the nipple, but there is some area of abnormality in this calcification, not like that plasma cell mastitis that radiate to the nipple.
Okay, what else? Excellent, well done, Suhair. Good observation. What else? There is an abnormal calcification or calcification different from the typical benign calcification you have seen on mammogram. You need to do spot magnification for that area to characterize it further. Okay, excellent, well done. Excellent, good observation. So when you have seen any abnormal findings, usually we said we have to look for after you describe the findings, okay, by locations, by characters and by locations, you have to look for any
associated any abnormality.
Could you find any associated features?
Yes, there is a focal asymmetry associated with this classification.
Excellent, well done. There is a focal asymmetry.
Asymmetry.
Excellent.
So I give it by RAT 3 for, but you have to do a compression, spot compression view or additional ultrasound.
What about the asymmetry? Which type of asymmetry? Which type of asymmetry?
This this area represent the focal asymmetry. Because
are you sure it is a focal asymmetry?
Because this global
is it
area
seen
of,
in the is it seen in the CC view? I expect you to ask me about the CC view.
The CC view, yes.
Because the asymmetry was more appreciable in the CC view, that is why I hide it from you.
Yes.
It is more appreciable here. And the calcification, yes. The calcification more appreciable there, but the asymmetry is more seen here. What else? What other findings? Did you observe another findings? Could it be relevant to this case? Yes, there are bilateral edema, but the edema, yes.
On the right
edema
side
is
more, on the right side, yes. I think it is just edema.
It is more on the right side, but might be relevant, but the edema sometimes it is gravitational. So if the patient lying on her right side more than left in systemic cause, you might find gravitational or dependent edema on one side more than the other. But here, since we have suspicious findings and the edema is more, so we have to consider it.
Yeah.
Yeah.
Yes, this risk.
What else? What else? What else? So
also,
now you can
also
say
skin thickening on the right side. More skin thickening on the right side than the left.
Yeah, so the breast and skin edema are more on the right side. The trabeculations increase global increased density, trabecular thickening, and skin thickening is more on the right side in the presence of this asymmetry and calcifications. So suspicious calcification, so we have to consider it as a positive or relevant associated feature rather than systemic cause. What else?
I'm confused about the right.
What other associated features? What are other associated features? The lymph node in the axilla are not visualized. So what else?
The right nipple. I'm confused.
Excellent.
About
what about the right nipple?
It is retracted.
Yes.
The right nipple is retracted.
What else other than retraction? Compare it with the contralateral.
Larger.
It is edematous, larger. Yes.
Enlarge, yeah, enlarge. The right nipple is enlarged compared to the contralateral. See, so all these are relevant features, are suspicious features. You see, are suspicious features. So next it will be ultrasound. And this is ultrasound. That is the asymmetry found to be a malignant mass. And this is the ducts, you see, associated with calcification, multiple ducts reaching the nipple, and the nipple is involved, see, enlarged and hypoechoic and with calcification, with all of the features seen in the index lesions are seen within the mass, within the nipple itself. See? And biopsy revealed invasive cancer, invasive ductal carcinoma. See? Okay. So here it will not be BIRAT 2. It's supposed to be BIRAT 0 on mammography base. But since the ultrasound was immediately available at concurrent time with mammography, it was BIRAT 5. See? And proven to be malignancy. What about these lesions? Do or not do? Still we are in BIRAT 2. Do or not do?
You have to do an ultrasound first because this is a circumscribed, partially obscured, high density lesion.
Is not BIRAT 2, is not fat containing lesions.
Yes, there is fat density. Yes.
So
Yes. Any fat containing lesion, you have to do BIRAT 2.
do or not do? Do
BIRAT
you agree,
2.
all of you? Do you agree BIRAT 2 or not BIRAT 2?
Any fat containing lesion, put it in BIRAT 2.
So all of
BIRAT 2.
all of the attendee are you agree about this to code it as BIRAT 2? No comment. So here, why you change your mind? Okay. You
Because there is fat
description as circumscribed, partial
obscured, but
and
there is
I shift you to fat containing lesions. Okay. So
I think this fat containing lesion along the part of obscured at the upper part of this obscured area. So the fat containing lesion, this large area containing fat, represent BIRAT 2.
So you are going to report it as BIRAT 2.
Yes.
That's why I brought this image. Abir, so here, stay with me, don't go. Don't close your mic. Abir, are you there? Disconnected. Okay. So hint.
I don't see it as a mass. This is the problem. I don't see it as a mass. Maybe it's I see the area just.
What about this convexity? Bulging. This is a contour, and
but the contour below it is retracted.
Huh?
I see the contour below it is retracted inward.
There is a bulge. You see, this is a contour here. This is a contour, and this is a mass, smooth, circumscribed, bulging from the contour. It is a mass. It is a mass, but is it circumscribed, partially obscured, or it is a fat containing mass? The real mass is not available today. Huh?
And this fat containing could just be the overlying breast. I don't see it within it.
Yes,
definitely.
excellent. Excellent, well done. You don't see it. Just I try to shift to her, but unfortunately she did not stick to her opinion.
But
She was correct. It's circumscribed, partially obscured. It's a partially obscured lesions, and sometimes people might get confused to say this is a fat-containing lesion. That is why I brought this image.
this area of fat, I think, not
Yeah, it is part of the breast parenchyma. It's an oval with partially circumscribed and partially masked or partially obscured. It's the phylloides tumor. You see, sometimes phylloides tumors represented like this. And this is a serious, because if I report a phylloides tumor as BIRAT 2, it will be serious problem, because the malignancy in BIRAT in phylloides is unpredictable by imaging. You know, the lesion might appear as probably benign on imaging, but pathologically malignant phylloides, and the reverse. You might see suspicious by imaging and just tend to be borderline or even benign phylloides. Phylloides is BIRAT 4. Usually phylloides from BIRAT 4, it has to be excised. See? If you report a phylloides tumor as BIRAT 2, it will be a serious problem. That is why I brought this. Usually or commonly presented like a circumscribed mass like this, unless it is so malignant and having a malignant features. Otherwise, it usually present like a circumscribed mass, but sometimes can be presented like this, okay, with the adjacent tissue containing the fat appear as if, because if you look here, as if it is seen in continuation. And sometimes the hamartoma, you see, having a capsule, a partial capsule, and part of which is encapsulated. We might get confused that this might be a hamartoma. It's okay. And this is more or less similar to that lesions, but it is circumscribed, partially obscured, seen on ultrasound as just a simple cyst, you see, representing BIRAT 2. This is the real BIRAT 2 lesions. And what about this? Where is Medina today? And where are they?
This is linear branching calcification.
Excellent, well done. So do or not do BIRAT 2. So this is not what?
Sorry?
Not a rod-like calcification.
Really, I put it as rod-like calcification.
That is why I brought. You see, I bring this image because you might mix with rod-like calcification. This is 1 minute. I don't know why yeah. Here, this is a rod-like calcifications. Compare this with the rod-like calcification. That one is irregular, heterogeneous density, heterogeneous in shape, heterogeneous in size. All are heterogeneous. And even the orientation, haphazard orientations. See, unlike the smooth, sharply demarcated rod-like calcifications. Okay, and what about this? Do or not do? Still we are in BIRAT 2. Do or not do?
2, fat containing.
Excellent. Do. Huh? Abir, Suhail. Heidi.
I put it as BIRAT 4. This is a speculated mass.
Well done.
35.
Well
طيب.
done. There is fat containing or no fat containing?
This large lesion containing fat, but this
How
upper
you can explain this?
Malignancy
upper mass,
Uh-huh.
it is dense and is with speculation.
Yes, yes, you have an speculated mass within a fat containing mass.
So a
It's
malignancy
rare-
originates.
Malignant trans.
Yes.
Hamartoma is a breast tissue in يعني normal breast tissue in abnormal locations. So maybe it can a malignancy can develop with them.
Yes, because it contains fat and fibroglandular, see, and stromal. Like the same component, the three components of the breast, you'll find it within hamartoma. Okay? If you remove the fat, it will be fibroadenoma. So hamartoma and fibroadenoma and phylloides are stromal, containing stroma as well as gland. See? But the fibroglandular component cancer can arise on a hamartoma like on the usual breast. But this is extremely rare. But just we have to be cautious. I brought just to be cautious. This is, yes, fat containing. Since you have seen a fat containing, don't rush and say this is BIRAT 2. In spite is a fat containing, but this is BIRAT 4C. And after ultrasound or mammography, after ultrasound, it is BIRAT 5. See, it is a BIRAT 5. This is the MRI of the same lesions. Okay, this is cancer arising in hamartoma. Okay,
The margin of the previous lesion, how we can describe the margin, microlobulated, or how can we describe
this
it?
one?
Yes.
Or on mammogram or ultrasound?
On both, can we describe it as microlobulated?
Here, this is speculative. Here, yes, ultrasound microlobulation, yeah. Indistinct with some microlobulation. Sometimes you might find mixed type. Here, indistinct with speculations. Here, there are microlobulations and indistinct border because there is a lot of reactions around the lesions, make it very indistinct.
So if I have speculation in mammography and then in ultrasound I don't see it, I will take with the most suspicious in mammography, yes?
Yes,
so I will.
Yes, yeah, you will take it by the most suspicious, yeah.
Okay.
Okay. How about this?
Okay, so an oval, or partially oval circumscribed mass.
Circumscribed. Oval circumscribed.
Yes, circumscribed mass.
Yeah.
So as it
Depends
is
on
really, if
diagnostic.
this or screening. If it is screening, I will put it 0 and request for ultrasound.
Okay. If I'll tell you it was seen on screening and after diagnostic, it is the same, it was the same, and follow-up 6 months performed. And it was stable on that 6 months.
Then
so this will be stable in the previous 6 months after screening. So this it will be after.
I would recommend another 1 year. It is BIRAT 3. I would recommend.
1 year.
So 6 months,
so
then 1 year. After
will be
another
Myra.
year,
This it
if
will be Myra.
fibroadenoma, yes. If stable
will
for
be
2
Myra
years, it
too.
will be Pyra 2. If stable for 2 years, at least 2 years, it will be Pyra 2.
Now, this is 1 year. This is the second follow-up.
So 3,
This
still
is
3.
the 1 year after the first screening. In between,
So
there was
still-
a 6 months and it was stable.
So
it
still
will
3.
be
3.
It's Pyra 3. This is
Yes.
Pyra 3, and you are going to recommend
Another,
the
yes, after 1 year. 1 year.
after 1 year. Yes. Okay. So Pyra 3 is probably benign findings. Okay, or probably benign abnormalities, probably benign mammogram. Okay, the risk is more than, as we said, more than 0, but equal to or less than 2%. And here you can tell me what are the lesions included in category 3. Usually, we are strict in category 3. What are the
Yes.
lesions being included?
Fibroadenoma. Fibroadenoma, which is not involuted and not complex, just fibroadenoma.
Okay, so how you describe it? Yeah. Yes. Yes. If you have a lesion on mammography, non-calcified, circumscribed, on ultrasound, typical fibroadenoma, yeah. This is Pyra 3.
Focal asymmetry.
Excellent, huh?
Punctate, group of punctate calcification.
Group of punctate, what calcification? What about the focal asymmetry? Yes, focal asymmetry, any focal asymmetry?
That is
no, become less dense on the spot compression view.
Spot compression view, yes, excellent. Yes, yes. Lesions appropriately placed in category 3 include non-palpable, non-calcified circumscribed mass, okay, on a baseline mammogram. Okay, and a focal asymmetry become less dense on spot compression and solitary group of punctate calcifications. Right. They are very strict classification to qualify a finding in the Pyra 3 categories. All the studies emphasize the need to conduct complete diagnostic imaging evaluation before making probably benign category 3. See? Don't rush and just report Pyra 3 before diagnostic workup. Okay? Hence, it is recommended not to use this in interpreting screening mammography. It's considered negative in diagnostic after diagnostic workup because there is no cancer. But if it's used in screening mammography, they consider it as positive. Why? Because another study has to be performed before next screening. However, this approach helps avoid unnecessarily biopsy, reduce an anxiety of the patients, and the reporting of category 3 varied among radiologists from different regions. What is the management recommendations? As you described, 6 months or short-term follow-up after the baseline mammography, you see, and then another 6 months, then 1 year, then 1 year, and not expected to change or follow up, but the radiologist prefer to establish stability before recommend routine screening mammography. Okay. We said if any change while screening, we have to upgrade the lesion to BIRAT 4 or BIRAT 5. And sometimes for BIRAT 3, might do biopsy. If, according to the patient willing or our physician. In this case, we have to report it category 3, okay? For instead of follow-up, biopsy is done due to patient preference or her clinicians. Okay, what about this? This study?
BIRAT 4. It's becoming BIRAT 4. Because it increase in extent and number.
الو
أيوة
شكله فصل.
أي كان انقطع.
فصل.
Okay. الو علق. Okay. We said, hello? We said screening mammography category 0 need additional. On screening mammography, we should not report it as category 3. We will categorize as 0 until diagnostic workup found to be the lesion is probably benign, then interpreted as para 3 assessment, and then after on diagnostic workup reported as probably benign, will give 6 months follow-up, okay? For the same breast being involved, okay? For 6 months from the initial screening mammogram being evaluated. If it demonstrates any change, increase in size or change in characters, it will be upgraded to 4 or 5, and then tissue biopsy will be indicated. And if the lesion stability confirmed and no new findings, then it will be still BIRAT 3, probably benign, for 6 months follow-up, okay? And after 6 months, it will be 12 months from the initial screening mammogram. So it will be evaluated. If there is any increase again or change in characters, tissue diagnosis will be recommended for BIRAT 4 or 5. But if it's still stable and no new findings, it will be reported as still probably benign, okay, and recommend 1 year mammogram. It will be 12 months from the latest or the most recent examination, but it will be 2 years from the initial screening mammogram, and again will be evaluated. If the lesion increase, then it will be category 3 or 4 or 5, and then tissue diagnosis should be performed. Or if being stable, no new findings, it will be category 2, because it will be after 2 years. And optionally, if the radiologist like to do another 1 year to establish the benignity, you see, or to stop here. Then after 12 months from most recent examination will be performed. Okay. So when we have to do category 3, it is strongly recommended category 3 only after appropriate workup. Perform initial short-term follow-up 6 months, then assuming stability, perform a second short-term follow-up 6 months. So from the beginning, if after diagnostic workup and still the lesion, it looks probably benign, this is the first time. After 6 months, stability. After 1 year, stability. Okay. And after 2 years stability, then it will be BIRAT 2. Okay. The third years, it will be just an optional. From the second year stability, it will be converted to BIRAT 2. Use in findings on mammography, as we described before, non-calcified circumscribed mass, solitary group of punctate, and for focal asymmetry. Regarding focal asymmetry, we said if diagnostic mammography depict a focal asymmetry with no associated mass, no associated calcification, no associated distortion, no associated any suspicious features, okay, and there is no sonographic or palpable correlate, in this case, you can report it as BIRAT 3, probably benign, okay, findings for follow-up. Use in a probably benign findings while the patients or referring clinicians still prefer biopsy. If they prefer biopsy, we should not shift to BIRAT 4. Still, we report it as BIRAT 3. Then we will add the sentence, instead of follow-up, tissue diagnosis will be performed due to patient or referring clinician concern, okay, or their willing. Okay. These lesions is circumscribed with associated punctate calcifications. You see, was not palpable, reported as BIRAT 3, and it was stable on follow-up after 2 years, then shifted to BIRAT 2 benign. However, the clinicians and patients, they were they want to do biopsy. Why? Because the radiologist was not able to give differential diagnosis for these lesions. That is why the clinicians prefer to remove the lesions or to do a biopsy. So we have to report it as BIRAT 2 instead of stopping follow-up. Okay, tissue diagnosis will be performed due to patients or referring clinicians' concern. And in this case, the result was benign vascular malformations. Okay, what about this? On mammography can be a BIRAT 3 or 4A, but after ultrasound, it downgraded to BIRAT 2. So that is why they prefer immediately to do workup, okay, to downgrade or to upgrade the lesions from just leaving the patients, okay, staying for unnecessarily follow-up. This modification has been implemented based on recent studies that have indicated full diagnostic Imaging evaluation will identify both benign and malignant lesion promptly instead of waiting for 6 months follow-up to obtain diagnostic workup. So if you have seen any probably benign lesion, don't just recommend follow-up. Try to clarify, do spot magnification view, do compression view, do ultrasound, okay? And then either downgrade or upgrade the lesion. If you could not upgrade it or downgrade it, then you can code it as BIRAT 3. So don't use BIRAT 3 if unsure whether to render a benign or suspicious assessment, then use category 4. Don't use in a screening examination, as we said, don't use if palpable lesions. This is a new recommendations. The new recommendations, don't use BIRAT 3 for a palpable lesions. Okay, so use for of probably benign assessment of for a palpable lesion is not supported by proper scientific data. However, other institutions, they are still use BIRAT 3 for those palpable abnormality if demonstrates full criteria of being probably benign. Don't use in diagnostic examination if additional imaging is required to make final assessment. Don't, if you did not complete the workup, don't put it BIRAT 3. Complete the workup. If you feel that these lesions need to add more imaging to further characterize, don't report it as BIRAT 3. Don't use BIRAT 3 if follow-up of a lesion previously assessed as category 3, increase in size or extent. If it shows any increase in size or significant increase, as you know, by 20% or more, then it has to be upgraded to 4 or even higher. And don't recommend MRI to further evaluate probably benign findings. What about these lesions? How you can grade, do or not do? Huh? Do or not do?
BIRAT 3.
Okay, BIRAT 3. Why it is BIRAT 3?
It is non-calcified, non-circumscribed mass.
But is it non-palpable?
I have to ask about this.
What do you expect?
Could be palpable. This is large
It's
mass.
expected. Yeah, it is expected to be palpable. It's being placed anterior. You see, at the
Yes.
fat glandular interface, at the anterior contour. So anteriorly placed, yani sizable mass like this, expected to be palpable. Okay,
Yes.
but it's non-calcified. But what about the criteria? If we ignore palpable, if we said not palpable, why you said it is BIRAT 3?
Non-calcified, non-circumscribed.
Non-circumscribed?
Yes, on the mediolateral oblique, it is non-circumscribed.
So if it is not circumscribed, why you put it 3? For BIRAT 3, you have to?
Non-calcified, non-circumscribed.
No, non-calcified, circumscribed.
Circumscribed, sorry, circumscribed.
So, is it circumscribed?
On craniocaudal, it's circumscribed. And on mediolateral, it be partially obscured.
Okay, so still partially obscured still is probably benign findings. Yeah.
Yes. Yes. But if it is palpable, I couldn't give it BIRAT 3.
You will give it BIRAT
4.
Which 4?
4A.
Yes, we should just upgrade it to if fulfill the criteria of BIRAT 3, but it is palpable, just we upgrade it to 4. Okay? One issue. But you did not ask for further. You have to go further, yeah?
To do ultrasound, yes.
You have to do further workup. No ultrasound, but you have compression.
Spot
What must-
compression view.
Demonstrate.
Well, circumscribe. Macro lobulated mass, high density mass.
But here is obscured.
Partial obscured, yes.
Yeah, it was not here. It doesn't show that it's obscured, but now it means, yeah. The obscuration of the margins, not like here. Here it seemed to be, yes, more than 25, but not reaching 75. But here, more or less, 75% of the lesion is obscured. So, and it is high density. So it will be suspicious. And I remember this, my case. It was also indistinct on ultrasound, and it was
yes. This is my question. I feel that some area is indistinct.
Indistinct.
The upper part.
Yes, it seemed to be indistinct. On ultrasound, it was indistinct, and it was a malignant lesions. But unfortunately, I did not find the ultrasound. Okay. This from the literature. Initial screening study for 20-year-old woman.
Okay. The mass is irregular.
Where is the mass? Where is the mass?
In the left breast, in the
Are you sure?
outer.
Are you sure? Are you sure it is the mass?
So asymmetry.
Which type of asymmetry? Asymmetry or focal asymmetry?
Focal asymmetry, because it's seen in two views.
Are you
then
sure
we need
it's the same? Are you sure this is the same lesion seen in the on CC and the MLO? How we could be sure about this? I will be sure.
In the CC, it is not adherent to the skin, but in the MLO, it is.
How we can be sure the same lesions we are talking in one standard view is the same lesion on the other view? This asymmetry in the two view having same size, comparable size. Agree? Having comparable density. Having comparable distance from the nipple. So we are talking about the same abnormality. Okay? This is we want to learn while interpreting mammography. Okay? So we are talking about the same lesions. So why we say this a focal asymmetry, not a mass?
It lacks the
full criteria of the mass. Okay. We'll see what are these criteria.
Okay.
We said this we describe already. It's okay. This is a spot magnification. It will help you.
Yes, in the spot magnification, if it was a mass, it will be convex and denser in the center.
It is a mass?
No, I said if it was a mass because you have
Yes,
asked
so
me why
it's
it's not a
confirmed.
mass.
So it's confirmed it is a focal asymmetry, not a mass.
Asymmetry.
Not a mass.
Yes.
Okay. So what about how you are going to grade this one? Category?
The two compressions, one is for the MLO and the other is for the CC, or what? Because
Yes.
so
Oh.
it become less dense on the compression.
Excellent. Yes, less dense on the compression.
So it will be para 3. Okay, it will be para.
It will be para 3 because it is still there, but it is less dense than the standard view. And why we said it is asymmetry, not a mass? It's lacking. It is scalloped or concave rather than convex. Okay, and it is not dense as the center.
Yes.
And it is due to intervening fat. Its density is heterogeneous rather than homogeneous, and it is fading away. Okay, the gradual transitions of the density toward the periphery, while the mass it will be abrupt, and it will have a bulging convex margins. Okay, so this is asymmetry because it is scalloped, heterogeneous in density due to interspersed fat, and gradual change, okay, in density at the margins. Okay, so what are the differential diagnoses? What is your differential diagnosis? What could it be?
Yes.
Are the differential diagnosis for asymmetry? If you remember from the lecture of asymmetry, what are the differential diagnoses?
Asymmetry. It could be following infection, following
mastitis, excellent. Well, mastitis,
following
one of the
trauma.
Trauma, excellent.
Yes. Any interventional procedure done before.
Okay. Following trauma, okay.
Hormonal therapy.
Hormonal replacement therapy, excellent.
And malignant causes, it could be, these are the benign causes. Malignant, it could be carcinoma.
Which type of carcinoma?
I'm not sure.
Could be invasive ductal?
Carcinoma.
Could it be?
Invasive ductal. I'm not sure. I don't know.
It could be. Could it be invasive lobular? Yes, invasive ductal, none otherwise specified. And it will not be papillary or medullary or this specific type. It will be the invasive ductal, not otherwise specified. You see, it could be invasive lobular and it could be lymphoma, or these are malignant. Could it be benign? Benign like what? Benign condition you mentioned, but benign lesion. Like, could it be a hamartoma? Yes, can be. Not typical, but it can be. It can be pseudoangiomatous stromal hyperplasia also. So the differential diagnosis, it could be normal variant. We forget to mention this is just parenchymal island. It could be just a parenchymal island, okay? Involuting parenchyma and this residual parenchymal island, okay? Fibroglandular parenchyma. So it can be normal variant, can be hormonal replacement therapy, okay? Asymmetry secondary to royal surgery from contralateral breast, removal of tissue there and persistence of tissue in the ipsilateral. It can be focal fibrosis, we forget to mention, pseudoangiomatous stromal hyperplasia, post-traumatic changes you mentioned, mastitis you mentioned, and fibroadenolipoma or hamartoma, invasive ductal carcinoma not otherwise specified, invasive lobular carcinoma, and lymphoma. And in this case, ultrasound demonstrates normal tissue throughout upper outer quadrant of the left breast. So it is benign focal parenchymal asymmetry, normal variant. So it will be BI-RADS
2.
2. It was BI-RADS 2, just for routine annual screening. But we have to be cautious in the case of this asymmetry. This is our patient. I miss Dr. Sarah. I'm asking about her. I don't know why she's not available today. Sarah Elmak, about this case. Okay? Huh? Suhair, Heidi, Abir. Abir, I don't know what happened to her. Might be.
This is craniocaudal and mediolateral oblique views of both breasts, showing an area of focal asymmetry at the upper outer quadrant of the left breast.
Upper outer quadrant.
Retroareolar.
Excellent, retroareolar. Or anterior third. Either retroareolar, like it is more retroareolar because it is in close proximity to the nipple. Okay, huh?
Appreciate, but not clear, suspicious calcification, most likely
It's not
representing.
calcification. This is biopsy clip.
Okay.
Hmm.
Associated with the retroareolar skin thickening and nipple retraction.
Not retracted.
No.
The nipple is not retracted, but there is subtle thickening, yes. Some thickening is there. Yeah, there is thickening.
Yes, no other feature, associated features, no calcification. I have to do a spot compression view for more characterization of this focal asymmetry.
Okay. I'll show you before the spot. I'll show you the 6 months
And
previous.
to see previous image, yes.
This is the previous.
The previous images showed I think it is stable in previous images.
Yes, stable. However, the skin thickening a little bit more. You see, by measurement, it was more. And if you concentrate here on MLO, you might find subtle increase and even here, see around the nipple, there is some thickening. It was not very clear seen here. So, spot magnifications. This is a spot magnifications.
Spot magnification view show confirm it is a focal asymmetry. I have to do ultrasound.
Before that, we said for the focal asymmetry to put it as BI-RADS 3 or BI-RADS 4.
This BI-RADS 3 because it is less dense than.
It is less dense? Are you sure it is less dense? No, it's not getting less. Okay, let me show you the previous one. Look for the previous one. Definitely, look here how it is dense and now it's fading. The density, look here how you can say high density mass here, but now it is less dense. But look for this case. It's just, it is magnified, it is near to you. But
Yes, the same density.
it's more or less, it doesn't fade away.
Yes.
It does not fade away. You see, and even there is any apparent convexity in the contour
Yes, there is
here.
convexity. Yes.
Yeah, there is some convexity, and there is subtle distortion, subtle surrounding distortion. And look, the nipple for the alveolar thickening. Okay, so it will be Birat
Birat 4.
4. Okay,
4.
it will be Birat 4.
Yes,
This
4C.
this is the ultrasound. Yeah, and here you can save, you can put it 4B. You see, 4B, because it can be inflammatory, it can be neoplastic. Okay?
Yes.
50-50. This is the earliest ultrasound. And this is the follow-up ultrasound.
On ultrasound, it shows low hypoechoic, irregular mass, and on follow-up, I couldn't appreciate on follow-up.
Okay, this is the earliest, this for image, this is the earliest. Demonstrate subtle distortion and altered parenchymal echogenicity. It looks a little bit hypo with some distortion and mild skin thickening. I'll show you later the clear area to compare with. Okay, and on follow-up, this distortion is getting more. Look here, the hypoechogenicity is increasing and distortion is more. Look for the tethering. This is the Cooper ligament tethered to overlying skin. And look even for the skin. Look for the difference. Look for the skin in the previous and look for the skin at the current. You see, there is more thickening and more tethering of the skin, more hypoechogenicity and distortion, and there is focal, was not shown in the same area, was not shown in the earliest image. But I was not sure if it was there, yani, passed over or just a new area. Because on mammography, that asymmetry, it was persist, the small area just behind the nipple. But with meticulous searching, we could appreciate these irregular lesions just behind the nipple, which make it more suspicious. More suspicious. And compare, you see, this is the other area away from the area of asymmetry. Look for the breast, how it is clear. This is the same breast. You see, this is just behind the nipple laterally, and this is medially. Look for it. It is very clear. However, look for the skin thickened. Compare with the contralateral, same breast, same area. This is the contralateral is clear, you see, but if you look for the skin, on this breast, the skin is thickened. But the findings are suspicious, and we recommend re-biopsy because the first biopsy was negative. Okay, this is another patient, 65-year-old female, screening mammography. Heidi, are you there or left?
Yes, Assalamu alaikum.
Alaikum assalam. Huh?
I think the lesion in the left breast speculated, irregular.
Okay. You mean there is a mass? We said before, we have to differentiate between the mass and asymmetry. And even if we have a mass, not fulfill the criteria of being a mass, okay, we describe it as focal asymmetry until we confirm it is a mass.
Okay, focal asymmetry.
So we are dealing with the focal asymmetry. Why it is a focal asymmetry? Yes, there is distortion. I agree with you, there is distortion. But I'll show you. Now you can see it closely.
Yes.
Is it a mass? Here, does it look a mass?
I think there is
Look for the center of which.
central hypoechoic, not like the peripheral.
Look
It's
for
like
the any convexity. Could you see any convexity?
I think it is architectural distortion.
Yes, there is asymmetry with architectural distortion. Yes, even here, I can say the same. I could not see any real mass to say there is a mass. I have an area of asymmetry and architectural distortion. Okay. When we go back, could you see anything else, or that is the only findings? Yes, same locations here. There is subtle.
Nipple retraction.
Yes, there is focal thickening, and faintly there is a linear density, okay, going from the lesions toward the site of the thickening. So the findings are suspicious. So it will be BIRAT.
BIRAT 4B or C?
Or 4B or C. Excellent. So, yes, this is the ultrasound.
Anechoic, irregular.
Hypoechoic, deeply hypoechoic. Okay, irregular, speculated.
There is a rim vascularity.
Okay, there is peripheral vascularity. And if you see it here, it is not the center. That is why you see the lesion is not a compact mass. It is a mass on ultrasound, but it's not as a compact mass. That is why it is seen like architectural distortion mammography is speculated. Here it is speculated and angulated, vertically oriented, deeply hypoechoic, posterior shadowing, adjacent satellite nodules, ductal extension down to the nipple, where the nipple also is hypoechoic with vascularity. And these are the adjacent satellite nodules. So, and this is another duct. So we are dealing with
suspicious lesion.
It will be BIRAT
4C.
Why 4C? Now it is BIRAT 5. Okay. After all this is BIRAT 5. See? Because this is the features are features of malignancy. These are typical classic features of malignancy. Highly suggestive of malignancy. Small lesion that is highly suggestive and proven to be invasive ductal carcinoma. This is a CT performed for had been performed for staging. Okay, look for the lesion, more appreciable on the CT than on mammography. And look for the ducts. That was the ducts going toward the nipple. You see, and here speculated irregular and the adjacent all satellite and ductal extension satellite nodules, and it was invasive ductal carcinoma. Okay.
Okay.
What about these lesions? This abnormality, mammographic abnormality.
Yes, segmental linear calcification.
Is it segmental? Is it segmental? أيوة, you are right.
Regional.
Regional. It is regional. Yes. The difference between segmental and regional is just the direction.
Okay.
You see, is more pyramidal, regional, segmental is pyramidal pointing toward the nipple, while regional just يعني has no directions, taking an area without a specific direction toward the nipple or specific pyramidal distributions or ductal distributions. So the segmental usually representing multiple ducts, and the ducts are pointing toward the nipple. That is why it is more suspicious, the segmental. While the regional, here we are taking the regional represent BIRAT, regional, any type of classification. If it is regional, it will be BIRAT.
BIRAT 2.
2, regional is BIRAT 2.
Sorry,
4B.
group is BIRAT 2.
4B, regional distribution is 4B. But here, this is, we're taking by distribution or by the morphology of the classifications.
Morphology.
Why?
Because it's more suspicious. It is linear.
Yes, yeah, it will be 4C because the more suspicious, so it will be 4C. It's okay. This is 4C, regional, linear, fine, linear, regional classification. Huh? BIRAT, let us go quickly. Huh? Straightforward, BIRAT.
Stay.
Sometimes you need to describe the lesion by one descriptor. Huh? What is the most important descriptor at for this mass?
Speculated.
What is the speculation?
Posteriorly and posteriorly.
Where is the speculation?
Posteriorly, posterior aspect of the mass.
No. There is no speculations. This is an indistinct mass.
Irregular, indistinct.
Indistinct. The only criteria is indistinct mass. See? So indistinct, it will be BIRAT and it is equal density. Indistinct, equal density. It will be BIRAT.
4B.
4B. And this lesion, it was an inflammatory cyst. Okay, it is 4B. Okay. So category 4 is suspicious abnormality, suspicious findings, suspicious mammogram, suspicious for malignancy. Whatever terminology you want to choose, you can choose it. Okay, is reserved for findings do not have classic appearance of malignancy but are sufficiently suspicious to justify recommendation for biopsy. Okay, it is between the ceiling for category 3 assessment, which is 22% likelihood of malignancy, and floor for the category 5, which is 95%. So it has a wide range of suspicious levels. That is why they prefer, okay, optionally to subclassify it into 3 categories, A, B, and C. A is low level of suspicions, likelihood of malignancy is more than 2, the ceiling of 3, okay, but equal to or less than 10%. While B is moderate level of suspicion, more than 10, equal to or less than 50%. While 4 is high level of suspicions, that is why they prefer to report it as highly suggestive of malignancy. Not highly, sorry, highly suspicious for malignancy, okay? But not highly suggestive of malignancy. The highly suggestive is BIRAT 5, but BIRAT 4C, it is highly suspicious for malignancy. Okay, the range of risk is between 50 and 96%. Most category 4 abnormalities are benign. but may require biopsy since this category can be malignant in 25 to 50% of cases. Malignant management recommendations is tissue diagnosis, but some patients, they might choose to decline recommended biopsy for category 4A. If they like, or if they're willing to take the risk, 10% risk, and just to follow the patient, to follow her, we have no problem, okay? Since the risk is low. Okay, when to do BIRAD 4? Okay, if sufficiently suspicious to justify biopsy. If sufficiently suspicious to justify biopsy, but the patient or referring physician, they refrain or they don't like the biopsy, we have to recommend biopsy and to add the sentence, biopsy should be performed in absence of clinical contraindications. And to be used in the presence of suspicious unilateral lymphadenopathy without abnormality in the breast. In the absence of non-infectious or inflammatory cause for adenopathy, especially if it is isolated unilateral adenopathy, then it has to be categorized as 4A if partially circumscribed mass suggestive of atypical fibroadenoma. See, if it is seen on mammography as obscured mass, partially obscured, partially circumscribed, on ultrasound not typical fibroadenoma, then we upgrade it to 4. If the lesion is solitary but palpable, circumscribed, and these but palpable lesions also, if the lesion is solitary, palpable, and on ultrasound giving a complex, and if probable abscess, also in these cases, we use category 4A. Category 4B for group of amorphous or fine polymorphic calcifications. Non-descript solid mass with indistinct margins, as we have seen just the previous examples. Category C, new group of fine linear calcifications, new indistinct irregular solid mass. And in this case, the CC mammogram demonstrates finding not reproducible on the other MLO, but it has, though it could be ectopic glandular tissue, but the appearance is sufficiently suspicious to be coded as BIRAD 4. So what about these calcifications? How you are going to code it?
Dystrophic calcifications.
Hint, today you are not concentrated. You are not hint as I know you.
So yes, polymorphic, I'm sorry.
Your answer today are not as before. You are doing well, but not as well as before. As good as before, as excellent as before.
Okay. So yes,
So,
it is
concentrate
yes,
on
of
this,
different.
Concentrate, little concentration, you will appreciate what type of these classifications.
It is of different size and shapes and density.
Yes, so.
Yeah, polymorphic. Yes, this is.
But look at the most of which of these. Look like.
What did I mention? What did I mention? Sorry, I said dystrophic. I mean coarse heterogeneous. This is what I mean.
Okay. Yeah, some area is coarse heterogeneous, but while the other area is this.
Linear. I think linear.
Linear.
Yes.
Linear.
Linear,
especially in the Yes,
if
especially
you have,
at the right side of the minute. Yes.
so if you have two type of classifications, you have to consider
The more suspicious.
in this
Mm.
more suspicious.
Yes, so it is
So you are
4C.
going to report the most suspicious.
4C.
So it will be
4C.
yes. You are going to report it. This is extensive type of classifications, but this high grade DCIS. This patient, high grade DCIS. This is by RAT 4C. Okay.
Mm.
And what about this? No other one
Amorphous.
want to share? Okay, go ahead.
The above one is amorphous, and the below one is
All
linear.
of the three are amorphic with some polymorphic. On the right, this one, some polymorphic classification, but are mostly this amorphous, or punctate. You can say this is punctate, this is punctate with some amorphous. Punctate and some amorphous. So
And
if you have a punctate or amorphous,
and
so
the one is linear. One is in
okay.
linear distribution. Yes.
The linear distribution, it will be
4C.
the morphology is not highly suspicious or is not a suspicious, but the distribution is
Suspicious, highly suspicious. 4C.
will be by RAT 4C.
4C.
4C by distribution. 4C by distribution. But this, it will be by RAT
4B.
4B. Yes. This will be 4B and this will be 4C. Okay. So the management recommendations for BIRAD 4A after biopsy result, if it tend to be a benign percutaneous result after percutaneous biopsy, benign result, just 6 months follow-up. See, it will be probably benign, just follow it up after 6 months. While for BIRAD B and C, it will be because the level of suspicion a little bit higher. So you have to look for the image and the pathology result, if it is concordant or not. See? And for BIRAD 4C, the pathologist may initiate further histologic evaluation of benign result. And the referring clinician may be better able to understand the radiology follow-up recommendations for finding place in each subdivisions in category 4. For these examples here, we have group of polymorphic calcifications. It can be benign, it is BIRAD 4B. The result was adenosis, sclerosing adenosis, and ductal carcinoma or ductal carcinoma in situ. So it is concordant. The findings, the pathology is concordant with the imaging. Both it can result in this appearance. Okay, this is 45-year-old female presented with right breast palpable mass. Okay.
4B.
4B. Why?
Indistinct margin in part of
margin, both in ultrasound and high density indistinct on mammography, indistinct. So it is oval parallel but has indistinct border on ultrasound. So it is BIRAD 4B, and the pathology was mucinous carcinoma. So it is concordant. Mammography appearance with the pathology are concordant. What about this?
This linear branching, fine
Linear branching, excellent. And
Giving a type.
this is the morphology, the distribution.
With the ductal extension. Ductal extension.
Ductal, one duct.
Segmental.
No, branching.
Yeah, so it is segmental. This is segmental. So it will be birat.
4C.
Why it is 4C? Why? You have linear branching, linear
4C.
and linear, fine linear, and fine linear branching, 4C.
4C.
And segmental, 4C. You have multiple high suspicious.
Yes, yeah. Give it birat 5.
Features. It's supposed to be
birat 5.
Supposed to be 5. Supposed to be 5 because you have multiple. Okay, so this is birat 5. Okay, what about this one?
5.
5, excellent. Why?
Hyperdense, irregular.
Yes.
Speculative.
Yes, excellent. Yes, it is. As you mentioned, exactly. Microlobulated and speculated and indistinct high density is birat 5. And this is straightforward. Birat
5.
5. This is the only descriptors with positive predictive value equivalent to birat 5 is speculated margins of a mass. Okay, so category 5 are highly suggestive of malignancy. Okay, or highly suggestive for malignancy. Classic signs of cancers. Probability of cancer more than equal to or more than 95%. Include speculated, irregular high density mass, segmental or linear arrangement of fine linear calcifications. You see, if you have fine linear calcification in a linear arrangement or in a segmental arrangement, it will be birat 5. Irregular speculated mass with associated pleomorphic calcification, it will be birat 5. So combinations of high suspicious features, then it will upgrade the lesion to birat 5. The management recommendation before it was appropriate action should be taken in the 4th edition, but the 5th edition provide more dedicated management or more directed management recommendations, which is percutaneous biopsy is very strongly recommended for pathological confirmation. Percutaneous tissue sampling to facilitate treatment options. Okay, so all category 5 abnormalities typically receive biopsy, and if the result of biopsy being benign, this automatically should be considered as discordant, okay, resulting in recommendation for repeat biopsy. Consider surgical excisions and surgical biopsy. So when we have to do birat 5, if combination of highly suspicious findings are present, assessment category is received for classic example of malignancy: speculated irregular high density associated calcification, new fine linear branching calcification, segmental or linear irregular speculated mass plus speculated pleomorphic calcification. Use the findings sufficiently suspicious to justify category 5, and the patient or referring clinicians refrain biopsy because of contraindication or other concern, then we have to code it as birat 5 and add the sentence: biopsy should be performed in spite or in the absence of clinical contraindications. Most non-palpable breast lesions underwent preoperative wire localization prior to excisions. They have to excise it and they have to take a good amount of tissue for proper diagnosis, okay, and proper treatment. Don't use it when only single high suspicious finding is present. See, then we have to use category 4C. For this, straightforward, it will be do or not do.
Virus
Do.
5.
Okay, and what about and this? Do or not do?
Do.
5.
Yes, virus 5.
Okay. No one read.
No, this is virus 6. Sorry.
This is biratic. Why? You should read. You have sentence written up. You have to read it. So this is
Proven. Already proven.
Yes, virus 6.
okay. So category 6 is reserved for lesions identified on imaging with biopsy proven malignancy. Non-cancer, non-malignancy, non-biopsy. But what? Any biopsy proven cancer, it will be category 6 or 13. Huh?
It's because in these lesions they didn't do surgery. They, for example,
Yes,
do adjuvant chemotherapy.
Prior to complete surgical excision. Prior to complete surgical excision, it is essential. Prior to complete surgical excisions, okay? And in which there are no mammographic abnormalities other than the known cancer that might need additional evaluation. If we have done a mammogram and the only findings we could see that corresponding to the known biopsy proven cancer, and this biopsy proven cancer, there is no history of complete surgical removal. These two are important, okay, to categorize the lesion by RAT6. And management may be used in this way to see how well the cancer responding to treatment. Like for neoadjuvant treatment patients, you see, this one of the indications for imaging, and we report the lesion as RAT6. So the management recommendation, it will be appropriate action should be taken. This is on previous editions, but the current edition, the 5th edition, provide directed management recommendation, which is surgical excisions is indicated when clinically appropriate, because the decision is on the clinical basis, not radiological basis. What about this example? This is our patients, 63-year-old female patients, known case of breast cancer on neoadjuvant chemotherapy. Do or not do? Do or not do? Do 6 or not do?
Do.
Heidi?
Yes.
Yes, you are right. Why we reported as or coded as 6? Yes, you are right.
There is response for the chemotherapy.
We have no baseline, but according to the current mammogram, I have features. I have suspicious feature on right or left?
Right breast.
Yes,
Right.
there are suspicious feature in the right breast.
Yes.
Okay, So since I have suspicious features and this patient known to have right breast cancer, okay, so it will be, and the patient just on neoadjuvant chemotherapy, so this patient, it will be BIRAT 6
6.
because the abnormality on the right breast, and this is the ultrasound, you see, but unfortunately there was no baseline, but these are the only findings. See, there is no contralateral, and this is locally advanced extensive malignancy in the right breast. So it will be BIRAT 6. So BIRAT 6 is appropriate assessment prior to complete surgical excision. Here, there is no complete surgical excision, so it will be appropriate. If it can be used after incomplete excision. If complete excision, then still we can report it as BIRAT 6. For second opinion of previously biopsy finding already known to be malignant after attempted complete removal of the target lesion by percutaneous core biopsy, like vacuum assisted, they are sucking some of the lesion. If there is attempt to complete removal of the lesions, and then you find imaging findings, it will be BIRAT 6. For monitoring of neoadjuvant chemotherapy, definitely no complete surgical excision, so it will be BIRAT 6. And BIRAT 6 should be used, performed after attempt complete surgical excision when pathology report indicate positive resection margins. If we have positive resection margins, but we should find mammographic features, suspicious features, other than suggesting of residual tumor, or other than the typical post-operative changes. Pathology, radiology concordant. Then we can use BIRAT 6. But if after attempt complete surgical excisions and the positive margin, okay, but mammography doesn't show any suspicious features, then in this case, I'm not going to report it BIRAT 6. So we have to report it as BIRAT 2 because the findings are only post-operative changes. But we have to add a sentence stating that the pathology report suggests the possibility of a residual tumor despite absence of mammographic correlate. So there is no mammographic correlate. We have to describe what we have seen only. If we did not see, we cannot. Category 6, okay, is not appropriate for mammogram performed following surgical excision of malignancy and pathology result indicate no clear margin, no tumor at the margin. If the pathology result revealed clear margin and we have seen any findings on mammography, we should not report it as BIRAT 6. Okay? And if post-lumpectomy examination demonstrates surgical scarring, but no visible residual malignancy, then we have to report it as BIRAT 2. And if there are, for example, residual or new suspicious calcifications, then the appropriate assessment, it will be BIRAT 4 or 5 because they need, okay, more actions. They need the current actions to be taken to do biopsy, okay? So we are not going to report it as BIRAT 6. We are going, because we have suspicious findings other than the known cancers that need, okay, new actions. Prior to complete surgical excision of a biopsy proven malignancy when breast imaging demonstrate one or more possible suspicious findings other than non-cancer, we should not report it as BI-RADS6. If we have seen another lesion than the non-cancer, then we have to consider it, okay, by the most immediate action should be taken. That is why we should report it as either 0 or 4 or 5, okay? And if we report it as 0 and turned out to be nothing, okay, then we will report it as BI-RADS6. But if it turned to be suspicious, then we will report it as BI-RADS4 or BI-RADS5. Okay. Thereafter, yeah, we will describe this already. If after workup, after 0, and we have done a diagnostic workup, and then we could find nothing, we'll go back and report or the code the mammogram and as category 6 assessment. Okay. Management considerations. Unlike all previous editions, the 2013 edition discouraged the use of category 4 and 5 assessment at the screening, instead recommending that all abnormal screening report utilizing category 0 as we mentioned before. And this is the new recommendation more closely reflects the binary natures of screening assessment, positive versus negative, and management recommendation, routine screening versus prompt actions. Either negative, BI-RAD 1 or 2, considered to be negative, then for routine screening. Or if it is 0, 3, 4, or 5, it will be positive, then prompt action should be taken. Further diagnostic workup. Why they don't like to use BI-RAD 3? Because they found unnecessarily follow-up of many lesions that could have been promptly assessed as BI-RAD 2, benign findings. Also, delayed diagnosis of a small number of cancer that otherwise may have been smaller in size and less likely to be advanced in stage. And the use of category 0 for all abnormal screening also will serve to clarify that the abnormal interpretation or recall rate reflects even those screening examination findings sufficiently abnormal to justify diagnosis. Why? Why they are using BI-RAD 0 even for lesions that are sufficiently suspicious to justify tissue biopsy, because those lesions still need further workup for staging, okay? For staging before to take a biopsy. They have done the further diagnostic workup, okay, indicated to do extent of the disease prior to biopsy. Okay. Also, in the management considerations, they encourage to use the numeric coding codes along with assessment category text. See, and as for many examinations, many findings or more than one findings can be present. The management sections report may include a second sentence. So you have to have one overall assessment, but for the other findings, you might add it as a second sentence with appropriate management. Like if you find in the contract, you have the most suspicious findings in the right breast, and the final assessment will be 4C or BI-RAD 5, but you have a probably benign lesion in the other breast, you might add another sentence that you have a probably benign in the left breast for 6 months follow-up. Okay, And we describe already the sentence, if suspicious abnormality is identified, the report should indicate that biopsy should be performed in the absence of clinical contraindications, and these recommendations provide for the unusual circumstances in which either the patients or her physicians might reasonably wish to defer the biopsy. They don't like the biopsy for any reasons. So we have to put this sentence, and the interpreting physicians has sufficient concern that the biopsy is warranted based on the imaging findings. And the management recommendations, okay, appropriately and effectively transferring the burden to establishing a contraindication to this recommendation to the referring physicians. So the radiologist is free. Okay, so management recommendation also, we say we have to make sure the lesions seen in different modalities is the same lesions, corresponding to the same lesions. Like in this case, the screening mammography demonstrate a nodule or a focal asymmetry seen on ultrasound as a lymph node. To make sure that this lymph node is concordant or corresponding to the mammographic findings, we have to do an actions. We have to make sure. In this case, they inject the contrast and another mammography being performed and the contrast seen here on the lymph node. And otherwise, if there is a cyst, they can spread the cyst and inject air and do mammography, or they can put a clip, okay, or a marker within the lesions and then repeat the mammography. And this is very essential to make sure we are talking about the same lesions. What about these lesions? It looks like obscure lesions, but it looks almost 75% obscure or something, and it is a high dense mass. So, and it is bulbable. It will be by RAT 4A at least. Then we'll proceed. Okay, we'll proceed for it is oval hyperdense mass with mostly circumscribed and partially obscured margins, but the ultrasound demonstrate what?
I think fibroadenoma.
Demonstrate complex lesions. You have seen multiple cysts. If it is a fibroadenoma, it is not a simple fibroadenoma. Yes, it will be complex fibroadenoma. But this is a complex vascular lesion, so it will be upgraded to BIRAD, at least BIRAD 4B for biopsy. So we have to, okay, and surgery confirm the lesion to be an invasive ductal carcinoma. So we have to be cautious. And if we are following, okay, the lexicons, everything will be, inshallah, will tend to be in the correct way. So management recommendations should be made based on the most suspicious. If diagnostic mammography indicates the presence of suspicious abnormality, despite absence of sonographic correlate, or the vice versa, the sonography demonstrates suspicious while mammography is not, we have to consider the most suspicious features. Okay, the most abnormal and the most suspicious features, as in this example also. Here, this is a case of complex fibroadenoma. On mammography, it's so smooth, oval, equal density, but here it is complex. So, since it is complex, we are going to recommend biopsy. And it was a complex fibroadenoma because we have to manage by the highest likelihood of malignancy. And in this case, here we have groups, multiple group, of course heterogeneous, but with fine polymorphic. So I have to, if multiple group of course heterogeneous, it will be BARAT 3. But presence of polymorphic calcifications, I have to upgrade it to BARAT 4B, and biopsy should be considered. And in this case, it was multifocal DCIS with area of invasive component. So management recommendation should be made based on the most suspicious findings. And if we have a group of classifications, may include punctate and amorphous, okay? If one predominate, we can use single descriptor. If the most of the group is punctate, we can say this is a punctate classifications. If the most of the group is amorphous, we can describe by amorphous. But if not one predominate, we can say a group of amorphous and punctate classifications. And if there is polymorphic and punctate, then we have to consider the presence of polymorphic and to recommend a biopsy. Again, if we look here, yes, I have a lesions with perilesion edema and skin edema, but this it will be BARAT 4 because it can be periductal mastitis or abscess or whatever, or malignancy. But on ultrasound, it is obviously okay, a malignant mass with ductal extension. So it's being upgraded. Okay, so I'll take by ultrasound features and be reported as BARAT 5 instead of BARAT 4 on mammography. Okay, BARAT communications. We said in mammography report, okay, the last item is to have to communicate with the referring physicians. Communicate unexpected findings with the referring physicians. Verbal discussion between radiologist and the patient or referring clinician should be documented in the report. You have to document the discussion in the report. This is medical legal. Verbal discussions, as we described, should be documented in the region, in the origin report or in an addendum. Okay, this is an example. It was discussed with the patient and referring general practitioner that in case of BARAT 4A, referral to the breast clinic is advised. The patient and referring clinician, general practitioner prefer to wait the result of the biopsy. Okay, addendum. The biopsy showed a fibroepithelial lesions. Like what fibroepithelial lesions? We mentioned those. Fibroepithelial lesions are fibroadenomas, amphiloides, tumor. Okay. Referral to the breast clinic was now strongly indicated and was put in motion by the general practitioner after telephone consultation. Diagnosis after excision, 3 centimeter highly cellular fibroadenoma. This is an example. So, okay. So examples for reporting or example of reporting, the report, it should be unambiguous report and meaningful. Writing a report for screening, it should following questions need to be answered. These following questions should be answers. Is the examination is normal, or is there any areas of concern requiring further evaluation? That is it. This is for the screening. For diagnostic, you see, is based on a screening study. Is anything confirmed? Are they finding consistent with breast cancer? What is the next step? A full diagnostic workup should be completed, which include additional view, ultrasound, all of these before categorizing from 1 to 5 based on the possibility of malignancy, and then recommendation for future actions where appropriate. And the impression should be a conclusion with a specific recommendation, you see, not repeat of what was said in the body of the report. We should not repeat again what we described there. We should just talk about the recommendations or the category and the management recommendation. As for any examination in which there are more than one findings, this we described already. We said we can add another sentence. It is important that the radiologist carefully read the mammography report before signing it. Right and left breast locations for mammographic abnormality must be correct and consistent throughout the report. Okay. The report should always be explicit in guiding the clinician on the future course of actions. See? And the phrase malignancy cannot be excluded should not be used in the report. The report should assess possibilities rather than express an informative warning. Okay? So, what about this case? How you are going to report this? Where?
Byra 0.
Why?
Because craniocaudal view, I couldn't see the posterior part of the breast, and in the mediolateral oblique, I couldn't see the inframammary fold and the full length of the pectoralis major muscle.
Yes, for the CC, yes. Then, but for the MLO, you have to ask about the posterior nipple line. How does it measure? You see, and the difference between the two. And here, the comparison on MLO is 10 and on CC is 7.2. So is definitely is inadequate.
Inadequate, yes.
So significant amount of posterior tissue is excluded from the CC. So you are going to report it as
Byra 0.
Yeah. First of all, the report should include the name of the patient and additional patient identifiers. Okay. Then clinical indications. Patient is 52-year-old female and is seen for screening by bilateral digital screening mammography. Okay, using computer-aided detections, for examples, comparison with studies performed at Kida by date 1, 2, 3. Then findings. Okay, the breast is heterogeneously dense via ACRC that may lower sensitivity of mammography or might obscure or may obscure small lesions. Okay, the same. Then repeat view are recommended to include more posterior tissue in the right CC projection. Impression, it will be category 0, additional imaging evaluation. So it will be the report. What about this? How you are going to report this? Would like to go a little bit quickly, huh? Where is the abnormality? In which side? Okay. There is focal asymmetry or global asymmetry in the right breast.
Yes.
Okay. So this is the okay.
So ultrasound show.
Same. The patient informations about the patient identity, and then bilateral mammogram indications for examinations, technique, okay, standard CC and MLO, okay, and adjunctive targeted ultrasound of the right palpable abnormality, or if it is screening bilateral ultrasound, you can just mention comparison, no previous exam available, findings, overall breast composition, ACRD, Okay, the breasts are extremely dense, which lower sensitivity of mammography. Central in the middle third of the right breast, a focal, this is my case, okay? A focal asymmetry concordant with a palpable abnormality, no associated calcification. However, there is associated mild edema and thickened retracted nipple, no mass asymmetry, architectural distortion or suspicious calcification in the left breast, unremarkable left breast skin and nipple areolar complex, no pathology seen in the visualized part of bilateral axilla. Okay, targeted ultrasound of the mass concordant with the lump and the right midcentral asymmetry on the mammogram. Ultrasound revealed an irregular heterogeneous hypoechoic indistinct mass with posterior enhancement and shadowing. Complex or combined, combined enhancement as well as shadowing, size equal 3.5 by 1.5 centimeter. So assessment by RAT 4C suspicious findings, the right palpable abnormality seen as suspicious mass, management, tissue diagnosis. Okay, this should be the report. For this, also my case, name of the patients and all information about the patient, bilateral mammogram. Okay, the other is not available here. Indication, follow-up of probably benign mass in the upper lateral right breast. Technique standard view, CC and MLO of bilateral breast. Comparison, the present examination has been compared to prior imaging studies performed at the same institutions on date so and so. Okay, three prior examinations as you have seen here. Findings, overall breast compositions, ACRC, the breasts are heterogeneously dense, which may obscure a small lesion. Interval stability of 4.5 by 2.2 centimeters circumscribed margin, oval shape, equal density, right upper outer posterior mass, not associated with other mammographic abnormality. Okay, no mass, asymmetry distortion or suspicious calcification in the left breast, stable mild thickening of the nipple areolar skin as sequelae of periductal mastitis on both sides, unremarkable, on the right side, unremarkable left skin and nipple areolar complex, no pathology seen in the visualized part of both axilla. So assessment category 2, why it is 2? Because this is more or less stable for 3 years. This is probably benign lesions on the first study and stable for 3 years, so it will be BIRA 2, benign finding. No further evaluation or further follow-up is required. However, because the doctor concerned, FNA was performed and revealed a fibroadenoma. Management is routine screening mammogram. Okay. This is also my patients. A bilateral mammogram indication, 36-year-old woman, known case of cancer for mammographic assessment. So, since it is known case, it will be
6.
It will be 6. Technique, standard CC and MLO, comparison, none, no previous. Findings, overall breast composition, SRB, scattered areas of fibroglandular density. The other is not shown here. An oval circumscribed high density, right lower outer posterior mass, size 5.9 by 5.5 centimeter, not associated with calcification, but associated with diffuse parenchymal and skin edema, trabecular thickening and skin thickening. and dense axillary adenopathy, not shown in this image. No mass asymmetry, architectural distortion, or suspicious calcification in the left breast. Unremarkable left breast skin and nipple areolar complex. No pathology seen in the visualized part of the left axilla. And the assessment category 6, non-cancer. Pathology proven malignant right breast mass. It was grade 3 invasive ductal carcinoma, and the management, it will be surgical excision when clinically appropriate. So these are 3 examples of a report. And in conclusions, we have to do mammogram, okay, for screening female above 40, and for diagnosis for palpable abnormality in their 30s. See, or if we have done, if she's young and we have do ultrasound and we find suspicious findings, then we'll go proven to be cancer, then a baseline mammogram will be performed. Okay, then if you have any abnormality, might need additional view. If this is BI-RADS 0, need additional views or ultrasound, and some of the lesions and some of problem solving might need to go further for MRI. And if all of these examination concurrently performed as the same day, then the final assessment should be based on all examination together, even if MRI is performed. But generally, the final assessment is used to be performed based on mammography and ultrasound. And always we have to consider, okay, the clinical. And just to remind you, by the structure report, include indications, breast compositions, clear description of abnormality. We have to compare with the previous, and then to give overall assessment category, and should be predicted on the basis of the most suspicious features. Accordingly, we will give management recommendations, and should be specified to certain BI-RADS categories. Okay. Just quickly, let us go through a few examples before we said goodbye. This is screening. This screening. What is BI-RADS? Just give me the BI-RADS.
0.
Which type? Where is abnormality?
The left breast.
Okay. For you is left breast. Could it be in the right?
Yes, it could be in the inferior part, inferior posterior part. Yes.
Yes, you did not ask about the other view. Okay. This is the CC view. Now it is more clear that it is
it is in the central and middle.
In the medial breast.
Medial.
And
yes.
Here it is more clear, the area of distortions and suspicious polymorphic segment. This is my case. And this is a post-neoadjuvant chemotherapy. Look for the mammography. Okay. Okay, this is the look for the previous. Look for this CC. This is pre-neoadjuvant, and this is post-neoadjuvant. More or less return to normal. You see, this is okay, improving. What about this BI-RADS?
Screening also.
Diagnostic. Breast pain.
Calcification. Just there is pleomorphic.
Excellent.
Calcification. and it is, I want to see if it is regional or segmental, just.
From here, you could not appreciate.
Segmental.
Yes, it is segmental.
Yes,
Segmental
especially in the upper part. Yeah, so it will be 4C.
This is the, now
4C.
this is the, yes, this is a 4C. Yeah. And it is a case of DCIS. It typically extensive DCIS. Okay. What about this screening mammogram?
The problem, the quality problem.
You could see nothing?
I mean from the.
Could you see this? Could you see this?
Yes, yes, multiple bilateral. Yes.
Yes, multiple bilateral.
Yes.
So this will be, and what about these calcifications?
These are round calcifications.
Round,
benign.
loose, and center. Yes, benign calcification, and these multiple.
Fat containing lesions, yes. 2.
So it will be BIRAT?
2.
2, excellent. This is BIRAT 2. This is steatocytomas multiplex. Multiple all cysts, non-calcified all cysts. Okay? What is BIRAT?
BIRAT 5.
Why it is BIRAT 5?
Because it is fine, polymorphic, and linear with segmental distribution. So multiple than.
Yes, at least 4C. I could not confirm if it is regional or segmental, but it's probably segmental. So it is fine linear and fine linear branching. It will be 4C, and if it is segmental, it will be 5. What about this one?
This also 4C.
Or this one, it looks more towards segmental. Yes, but this is 4C or 5. Agree with you. And here, this one.
This is polymorphic, segmental. I think segmental.
Why polymorphic? Polymorphic, if you remember,
linear.
there is one
linear.
word. It's linear.
Classification, yes.
This is linear. So the 3 examples are at least BIRAT 4C.
4C.
If confirmed, this is the only one it seemed to be segmental. Appearance look like segmental, it will be 5. But this might be segmental or regional. If it is segmental, it will be 5. If it is regional, it will be 4C. Okay. So all are examples of high-grade DCIS. Or most probably it will be segmental or extensive. Okay, and here 1 and 2.
1, it is BIRAT 2, circumscribe oval, equal density mass.
So here 2. What are the 2?
2, it is partially circumscribed, partially obscured mass.
Where?
I'll give.
You get confused. We are at the end. And today,
this for the same patient or
we went
for the same
so quickly.
patient?
Speculated?
No. For the same patient?
This one. No. What about this one?
This is a partially circumscribed, partially obscured mass, high density mass.
This is indistinct. Because throughout I could see nothing. You see, it is indistinct. It's masking. masking. So it will be
Birat 4B.
This is Birat 4B, but fortunately, this is an inflammatory cyst. See, that is why it is 50-50. The indistinct. Sometimes you have benign lesions can give you an indistinct lesions. But this is, yes, this is circumscribed oval.
Oval
But
shape.
oval shape is Birat. Unless it is fat containing, it will be Birat 3.
3, yes, 3.
3. Circumscribed Birat 3. Oval Birat 3.
Yes.
But we said unequal density. This, at the end, you see, previously, these are reported as Birat 3. But recently, they said the probably benign lesion, if it is palpable, they upgraded to Birat 4B.
4A.
B4A, I mean, unless on ultrasound showing typical fibroadenoma. And this lesion, it was fibroadenoma on ultrasound. But
the nipple, what about the nipple? Why it is, it seems
no, nothing.
Oh,
No, projections or
okay.
nothing. There was nothing. It is not significant. It was not significant. She is my case. Was not significant. But if I remember this, I think a complex fibroadenoma being even upgraded in I showed you, if I have seen to I have shown to you in previous examples, you see, but you forget.
It was partially cystic.
It was partially cystic. So it was complex fibroadenoma being upgraded by ultrasound, biopsy performed, and it was just a complex fibroadenoma. Okay, for excision. And this here.
Birat 2.
Yes, both are 2 because it contains fat. Here now the fat is within the hematoma. This is very, very classical, very clear. This is my patient, but this is from the literature. Both are Birat 2. And this
Birat 5.
Straightforward because
Speculated
mass. Because it is a mass. It has convex
borders
and dense,
high.
abrupt. The density is abrupt from the margins. At the margins is not
دكتور
fading.
رباب معلش عندي سؤال في الكيس اللي فاتت. أحيانا ما بقدر أحيانا ما بقدر أعرف السبيكيوليشنز كويس، يعني كنت حاسبات زي المايكرولوبيوليتد.
Sometimes you will see both. You see the microlobulations here. Yes, there are microlobulation, but at the same moment you have long spicules are radiating. You have seen these thin lines, but
yes.
But at the same moment, the denser region is microlobulated. But at the same time, you can describe it by both. You can but because the speculations is more suspicious,
yes.
that is why just you can say an speculated mass, that means the highly suspicious.
Okay.
Even I might not need to say irregular, high density, and all these. Just one descriptor here is enough because the positive predictive value is very high. It is Birat 5. So no need to describe it more. When I said just a speculated mass, no need to describe it as high density. But if it is microlobulated, it will be positive predictive value Birat 4B, only 17. I would like to add more descriptors, might upgrade it.
Yes, okay? Like hyperdensity.
Irregular, high density, associated calcification, associated distortion, associated edema, all other factors, you see, other associated features will upgrade the lesions.
اوكي يعني لو كانت مثلا حاسة microlobulated وهي hyperdense كانت حتكون
So in
forced.
summary, we reach the
يعني لو كانت هي ما كان فرضنا إنه ما في specules لكن كانت microlobulated و hyperdense حتبقى 4C.
Yes. If it associated with micro classifications, polymorphic micro classification, then it will be
حتبقى 5.
Yes. The more you add suspicious descriptor, the more you upgrade the lesions. But you consider the positive predictive value for each descriptor.
Okay.
So we read the summary. Recommended to use the guidelines for writing such reports based on breast imaging reporting system developed by the American College of Radiology. Do not use terms different from the latest editions descriptors, okay? Use the latest edition descriptors. Mammography report should be succinate and accurate. An important medical documents report should be standardized, clear, and judicious. See, since many lesions are not clearly benign or malignant on mammography, reporting must often deal with possibilities rather than certainties. So there is some flexibility, okay? Descriptions of detected abnormalities and recommendations for subsequent follow-up studies should be included in the report. The final assessment and recommendation should be specified to certain BI-RAD categories. If mammography and ultrasound are performed, always describe in 2 paragraphs. As we have seen on the report, 2 paragraphs in the same integrated single report. But we have to conclude by one final assessment when sonography used as adjuvant study, combined findings of both studies should be applied as single or one BI-RAD category. Okay? Overall, final assessment of findings may be based on all imaging studies performed that day, and management recommendation should be based on the most worrisome of the features. Verbal discussion between radiologist, patients, and referring clinician should be documented in the original or addendum report. Category 3, 4, or 5 assessment is not recommended for screening, although in some instances a high suspicious abnormality may be identified that will warrant a recommendation for biopsy. Thank you very much. I hope it was useful session and you get benefit from it.
For sure. Thank you.
Thank you,
Thank you
Dr.
very
Rama.
much.